Good morning, sir. Today we have Dr. Shubhanshu sir with us. Thank you so much for taking out the time to speak with me today. It's an honor to have this opportunity to discuss colorectal cancer and its significance in our society. Given your expertise and extensive experience in the field of oncology and surgical oncology specifically, it's our honor to talk to you. Now, colorectal cancer remains a significant challenge for our society. So I'm eager to learn from your insights and approaches regarding treatment or regarding the clinical aspects of colorectal cancer. Shall we begin, sir?
Sure. Thank you, Dr. Ramdev. Being, I think, administrative manager.
And
Yes, it's
so,
it's good. And I have learned easily like what is the society and what it is for, what it is working for. And I feel it is good for the upcoming surgeons, upcoming students who wanted to become surgeons. And it's a good initiative. And before you introduced me about this society, I didn't let's say I ask you so much in detail what is it, how it is working, what it is. What myself, Dr. Shubhanshu, a working here in SRMS for the past 10 years in the division of surgical and bowels, and we are doing two on cases. We have a department which has medical onco, which is radiation onco and surgery division. Surgical divisions team is team at Parani. The relations with our produce and liquor care machines. So we all work together for the betterment of patients because cancer care is a holistic approach, not an individualized treatment by one surgeon or one radiotherapist. It is a holistic. We all need to work together so that the outcome of the patient should be the best.
so related to colorectal cancer, I firstly ask, sir, what are the common presentations? What are the typical symptoms that you see in colorectal cancer clinically and in the patients usually?
Since, as you told me, this is the talk is for the students. So what I feel is they should know what is colorectal and what is colorectal cancers. Basically, colorectum is the part of the large bowel. It starts from the distal end, where the cecum and ileum mix, and it includes your cecum, ascending colon, the flexures, transverse, descending colon, up to the sigmoid. That constitutes the colon, and rectum begins from the rectosigmoid junction down up to the anorectal junction. Now, why we have differentiated this, or I would like to stress this, because the management part and presentation both are different in colon cancer and rectal cancers. As far as colon is concerned, you'll take different symptoms, different prognosis, different management. Rectal cancers has altogether different presentations and different management. So I think we need to separate this first. It's a common terminology, colorectal cancers, but colon is separate and rectum cells. As far as presentations are concerned, the colon cancers usually presents with features of obstruction because they are more on the right side. So they present with long-term anemias, long-term bleeding like malinas. Okay, over a period of time when they become extensive, they cause obstruction of the bowel and the features of subacute section would be there. Versus rectum, they are more early presenting as a bleeding TR because distal bowel close to the anovage. So more commonly they present with the bleeding TR. Immediately, say over a period of months, they will come to something called as altered bowel habits. Now, what this altered bowel habits is, it's like a patient will be going for sort of obstruction, like bowel is he won't be able to defecate properly. So they will consult some physicians or over-the-counter drugs. They will take some laxatives. So that laxative will cause loosening of stools and they will pass some stools. So again, they will have feeling that it's fullness. What does that mean is they aren't able to defecate completely. So it's something called as spurious diarrhea. Spurious diarrhea means it's not a diarrhea. It's frequency of going to the toilets in a means for defecation. But since mass is there, which is obstructing the bowel, they are not able to defecate properly. So that is called as altered bowel habits. That's the most common. Second most common symptoms after leading rectum, which patients do come to us for carcinoma.
Okay, you already cleared a myth of mine that colorectal cancer, there are two different sets of cancer, colon cancer and rectal cancer. Are there any other associated myths with the colorectal cancers that you find in patients or in the attendants? It could be the myths regarding even cancer also. Those like godly cancer. What are the common?
Yeah, it's a good question because this is the thing which we do encounter in our day-to-day practice, because most of the majority of the patient comes from a low to average socioeconomic status. Even we have seen these problems in higher or well-educated families. The first myth is biopsy. That is the most important thing, because all of the patients, majority, in more than 90-95% patients, they don't want to get biopsy. They have a misconception that if we somehow meddle the tumor or meddle the tissue which is suffering from disease, the disease will increase very rapidly. So they don't want to get biopsy by any chance. They want to get rid of the disease without getting diagnosed. That is there the problem comes. Issue is they won't get biopsy. They won't get diagnosed properly. So what happens? They'll go to some periphery, some sort of quacks, and they'll get treated. And during the time, the crucial time will be lost, because they won't come to us. They won't get diagnosed. So they will be treated by poets which don't know what is the diagnosis. They'll be just giving them medicines or whatever sort of treatments. And that crucial time of intervention, where we can save the lives, where we can diagnose them early and treat them properly, that time is lost. That is the most important misconception I would like to stress.
After talking about the diagnosis, what are the current treatment approaches that are available for treating colorectal cancer?
Can you repeat?
What are the treatment approaches that are available for treating the colorectal cancer?
Now, as already told, like colon cancer are separate versus rectal cancers. So the treatments and evaluating methods are different. As far as colon cancer is concerned, the first modality of investigation is to diagnose, that is with the help of full colonoscopy and biopsy. Prove it is a malignant disease. Then we have to stage the disease with the help of contrast analysis, CT scan of the abdominal pelvis. As compared to rectum, here we can diagnose with the help of rigid sigmoidoscopy itself and biopsy. And again, evaluation either with the help of MRI pelvis and abdomen to rule out liver mets and other extension, or with the help of CT as well. Preferably we get MRI because that has a better soft tissue delineation. So we'll be staging it in a better way. Let's come to the diagnostic part. As far as treatment is concerned, a treatment depends on the stage of the disease. If it is a colon cancer, depends on the what stage it is, like early or locally advanced or metastatic. Similarly, rectal cancers, two things are there. First is what is the stage, second is what is the site of the disease. I'll explain it in deeper way. Shall we go for colon? Okay. Now colon cancer, I told, depends on the stage of the disease. The early stage, what we call it as when the disease is limited to the bowel or minimal extension for the nodes. That is considered as early case. That is T1 or T2, as we call it as TNL staging. T1, T2 or N1 disease is early stage, where we'll go for radical surgery. Then depending on the factors which comes after the pathological report, we can add on some sort of chemotherapy. If it is locally advanced, again prior surgeries must followed by chemotherapy. The difference is in early stage we may or may not add chemotherapy, depends on the risk factors. Say for example, if nodes have extra capsular extension, or we have some margin positive, or we have some high risk features, then we may add chemotherapy in an adjuvant form for early disease also. But once it is locally advanced, definitely we have to add chemotherapy. This is the difference to healthy. Yeah, T3 or N plus. And then chemotherapy is must. That is considered locally advanced. Early is T1, T2 or N very minimal like N1. Hey, we have subcategories. In that case, we may not add adjuvant. So that is the difference between the early and locally advanced colon cancer. Now coming to rectum, I would like to stress here there are two things which we need to consider. First is stage of the disease, definitely. Second one is the site of the disease. Now, why the site? Is because we have divided rectum into upper, middle, and lower part. Now, thing is, if you go to the anatomy, the rectum is partly intraperitoneal, partly retroperitoneal, and partly completely extraperitoneal. Okay, as you come to the lower rectum, it is totally extraperitoneal. Middle rectum is partly intra and partly retroperitoneal, and the upper rectum is intraperitoneal. So that's how the treatment also lies. Second issue is we should know whether we are going to save this feature or not, because the treatment of rectum may land up in something called as abdominopterygian resection. That means you are removing whole of the rectum along with anal canal, and patient will be having a permanent stoma. Stoma means permanent passage of stools through the abdominal wall. So should we avoid that? So that is the concept which has come. So for that, we need to know whether it is upper, middle, and lower rectum. And second is the stage of the disease. Depending on that, treatment is decided. Suppose it's early disease and the disease is situated in the upper rectum. We may directly go for primary surgery, followed by adjuvant treatment if required. Now, once it goes down, suppose it is in the lower rectum, same disease, early, but in the lower rectum, where we are not sure or surgeon is not sure that he can save this feature. So in that case, he may add neoadjuvant chemoradiation. It is another modality of treating rectal cancers where we are adding radiotherapy in first phase. So that's the way we decide upon the treatment part. So by and large, we have colon and rectum. In colon, we have surgery followed by plus minus chemotherapy. In rectum, we have surgery followed by chemo or radio. In some cases or advanced cases, we have neoadjuvant radiotherapy followed by surgery, followed by chemotherapy. So what I mean to say is, in rectum, radiotherapy has a role. As well as in colon, by and large, radiotherapy is not indicated. So that is the difference, and that's why we are stressing like colon is a separate entity and rectum is.
Okay. So, sir, you have been treating so long the cancers. What is the incidence of colorectal cancer, and has it changed over the time? Another thing is, what is the common history that you find in the colorectal cancer patients, and what are the, according to that history, what are the risk factors for colorectal cancers?
Yeah. Colorectal cancers, if you take the worldwide data, it is the fifth leading cause of cancers overall. And as far as prognosis is concerned, it is coming little down, say sixth or seventh as a cancer-related deaths. Cancer-related deaths in the sense the person dying from cancer. So it is coming lower down because the prognosis is better over a period of time. But as far as like trend is concerned, the number of cases are increasing. That may have various reasons. Say, for example, the dietary habits have changed over a period of time. The diagnostic methods have improved over a period of time. The patient's psychology has improved in the sense, even the minor symptoms, they are going to doctors, they are getting evaluated. So, many reasons are there that is showing the incidence is increasing. But prognosis is also improving over a period of time with the help of newer modality of drugs, better surgical techniques. We have better radiotherapy machines. So both the things are there. Incidents are increasing as well as the prognosis also is.
So, as you told about the history and things, are there any genetic factor involved with this? And is there anything that a person can personally prevent that can protect or save them from colorectal cancer? Yeah.
Sure. As far as colorectal is concerned, we definitely have identified certain risk factors in the form of genetic, familial, as well as the environmental factors. as you stressed upon genetic factors, definitely we have so many genes which we have identified, like APC genes is there, which is on chromosome 5q. Deletion of that will cause is one of the most important factor which we have diagnosed so far. It's an autosomal dominant disorder. That means if a person is having that abnormality gene, 100% transmission is being seen. Means the offsprings are going to develop type 1 cell. Similarly, we have something called as HMPs, that is hereditary non-polyposis colon cancers. In that also we have identified so many genes. Other than that, we have Pearce-Sagers. There's so many syndromes which we have identified to be a causative or risk factors for causing colorectal cancers. As far as screening is concerned, yeah, in Western world they have started screening in the form of regular colonoscopies. We have fecal occurrence blood testings. They have laid down even a protocol that how the patient should get evaluated, those who are at high risk. So that we can diagnose them early and treat them in a early disease. As far as India is concerned, screening programs have not yet been standardized. But what we recommend or what has been recommended by the books, in the sense, if we diagnose some case who has some genetic history or we have diagnosed some genetic abnormality, in those cases, definitely we tell them to undergo screening. Screening, like if a person is getting diagnosed with colon cancer, like he is having APCG mutation. So we tell them like their offspring should undergo screening at least from 20 years onwards in the form of colonoscopy every 3 years, then every 5 years. Fecal local unit testing is there, that also is to undergo. So like that, we have tests which can help persons to identify the disease early. But generally, these tests are not recommended in all the persons. Yeah, in high risk, where we have family history, where we have offsprings or relatives who are suffering from the such disorders, yes, we recommend that.
Said you already called about the prognosis of the colorectal cancer. You told that it is fifth leading cancer cause, but seventh in the deaths related to cancer. So, in general term, what is the prognosis of patients that have colorectal cancer? It is actually subjective. I understand that it depends upon the staging of the cancer also. I also want to know the reoccurrence of cancer. How frequently does the colorectal cancer reoccur? He say that triple negative breast cancer is almost certain to reoccur, 95% chance are there. So is there anything like that in colorectal cancer also?
Yeah. Recurrence is another huge topic because we have identified risk factors where chance of recurrences are. Similarly, again, I will differentiate colon cancer is different and rectum are different. So over a period of time, people have seen like rectal cancers, despite of extensive surgical resection, there is recurrence. And local recurrence is very difficult to treat because pelvis is not. So there are so many trials which is being done. And then people started adding radiotherapy after the surgery also. And they have found a decrease in local recurrence. There is something called a German trial where they found that surgery alone was causing almost 50% recurrence. That is, out of 100 patients, 50 were dying recurrence. But after adding on radiotherapy, they have found that local recurrence has come down to 20%. That is from 100%. From out of 100 patients, only 20 had recurrence. So there was a huge difference. So them new protocols being laid down. And nowadays, we are trying to decrease the local recurrence. Definitely stage has a goal. The early stage, the better treatment. The advanced stage definitely has high chance of recurrence as well as high chance of metastasis. Similarly, in colon cancer as well, the earlier the treatment, the better the prognosis. Another thing is, if patients are coming early, there's a new modality which has come up that is called as endoscopic surgeries. There, instead of having surgery from the abdomen, from the colon itself, we put some cameras and take out the disease from its side. So it's a new thing which is coming up. But again, depends how the patient is in stress.
Talking about this, is there any patient education part that you want to tell patients or you always want your patients to know about colorectal cancer?
Yeah, that is very important. So we have already, all of us have learned like prevention is always better than cure. So from the patient's part, we do tell them about the awareness in the sense their dietary habits, their lifestyle changes. This has a role because we have seen these are the risk factors which is causing colorectal cancers. Second thing is the family factors. Anyone in the family who is having such problems, we will tell them to get screened. We will tell them to get proper diagnosis of the disease plus any family or mutation histories that we would like to write. Eye screening protocols will tell them to follow. We have seen so many patients here also in this city where they are suffering from familial disorders, and we are trying to get them tested. And if we suggest, definitely patient will follow. So it depends like how well you are trying to convey your message to the patient. They understand, they do follow the request by the doctor.
So now the questions will be more oriented towards the aspirant. So answers would be like those actually guiding the aspirants. So my question is, what are the new advancements in recent year about colorectal cancers and the procedures or surgical procedures that are followed in colorectal cancer that you would like to mention?
So, coming to recent advances in diagnosis, as I already told, we have newer MRI, we have something called as transrectal ultrasounds, we have PET scans. So these are the new thing which is coming up and now getting standardized even by NCCN guidelines. They are telling for the early disease you get transrectal ultrasound require PET scans for a locally advanced disease to diagnose the metastasis. We have molecular testing though to diagnose whether it's the incident case or the first case of the family which is causing the immediate cancers. As far as treatment is concerned, one I already mentioned, there is something called as endoscopic treatment. There we are using endoscopes or videoscopes through the transrectal route and trying to remove the disease. Now we have robots. Even our institute has robot. We are using that so that something called as minimally advancement of minimally invasive surgeries, where we are using robotic surgeries to perform the surgery. Coming to the concept of surgery, yeah, something called as T&E has come for rectum. That is called as total mesorectal excision, in which we'll remove whole circumference of the disease. Because if you come to pathological margins, circumferential margin is also important. So there is a concept called total mesorectal excision that is also coming. So that has shown to improve, further decrease the chance of local recurrence. So there's a few things which is coming up. It's been helpful for the patients.
You just talked about the laparoscopic approaches or minimally invasive approaches, and you also told that our institute is having robotic surgery branch. So, how do surgeons decide which approach should be taking? It must be an open surgery, it must be a surgery from endoscopy, or it must be a robotic surgery or minimally invasive surgery. What are the how do the surgeons decide actually what to do?
As far as endoscopies are concerned, there are still limited indications like early disease in the form of T1 should be well differentiated. First thing, it should be accessible through the endoscope, so it should be lower rectal or mid-tracheal disease. Then, with the help of imaging, we should rule out any there is no nodal metastasis or any distance metastasis. So limitations are there for endoscopy. But for early diseases, definitely it's a boon for the patient because we are avoiding major surgeries. We are just doing a routine endoscope. Patient walks in, we perform the treatment, and patient can walk out maybe in a day or so. As far as differentiate like how to go for open surgery versus minimally invasive approach, again depends on few factors. First thing is the extent of the disease, definitely. Suppose for a colon, if it is a very extensive disease, there is no point in doing laparoscopic or minimally invasive because it's very difficult to take out everything. But now, minimally invasive being standardized in colon cancers, all of the surgeries like hemicolectomies, uvenomintectomies, whatever procedures are being performed routinely, and it is a standard of care. It has been proven by various trials that there is no difference between the prognosis and outcome of the patients as far as open versus laparoscopic surgeries. Robotic surgeries is a further advancement of minimally invasive. So it has a much better because of precision as well as approach. So definitely it is further step ahead of minimally invasive, that is beyond laparoscopy. So by and large, these procedures are to be applied if facilities are available and expertise. So no doubt, minimally invasive has come up in cancer surgery, especially in colon cancers and rectally as well.
What are the common intra-op challenges and post-op challenges in colorectal cancer? And what are the skills that you think a good surgeon requires for operating the cancer and handling out these challenges? That is either intraoperative or post-operative.
As far as complications are concerned, that's what you mean, no? Complications. So, as far as complications are concerned, intra complications like any other surgeries, chance on bleeding is there, chance of tumor perforation is there. But with the help of over a period of time, the surgeon's skills have improved by instrumentation as well as by training. Now we have separate colorectal branches. As far as Western world is concerned, colorectal surgery is altogether different branch. So that means the person or a doctor is getting trained in such a branch for a period of years and then come out and perform the surgery. So definitely the skills will improve once you are trained in one particular entity. So as far as outcome is concerned, like what the surgeon should think while doing surgery. Yeah, training does have a role as far as surgical skills are concerned. I feel it's not a very much different. If you perform or you do surgeries in a one particular branch over a period of time, you will get trained in that and you will learn how to model the tumors, what things you should be able to remove, what things you will not be able to remove. So that depends on the training you are letting. That is a holistic approach of treating a cancer. So it's not like all cancer you treat surgically. Sometimes it is beyond the scope of surgery. In that case, we just do the minimum thing for the patient. It's not like you will remove everything and then subject the patient for morbidity. So that things needs to be considered, like when to operate and when not to operate also.
Okay. You told that there's a big role of training in the surgical skills. So now coming to the training part, what are the pathways to become a colorectal cancer or onco-surgeons, and what are the qualities that you need to have?
Okay, as far as India is concerned, we have a very good program super running down, but it's very very extensive. So in the sense, first you have to do MBBS and internship, then MS in general surgery. If you are going for the specifically cancer surgeons like oncosurgery, you have MCH in oncosurgery as well as your BNB in oncosurgery also. In both these cases, uh, it's a 3-year training program which is running by NMCs and DNBs where the surgeon will get trained. Now we have carved out NCH in head and neck oncosurgery separately, any oncosurgery separately, and the best of the oncosurgeries be kept in separate entity.
Only there's always a teamwork. Team dynamics are always essential and vital part of a treatment. So, what are the dynamics of team that across the treatment of colorectal cancers?
Yeah. Surgery, not in surgery, even in cancer surgery specifically, I will tell, it's a teamwork, definitely. Teamwork in the sense, as far as surgeon's task part is concerned, you have counselor teams, like what has to be done. Next is surgeon's main role, what needs to be done. During the surgery, you have a team of your assistants, you have a team of body technicians, you have a team of anesthesia. All of them plays a very crucial role because anesthesia will take care of intraoperative as well post-operative pain management. Your surgical skills definitely will be affected and your team members are not good enough. Second thing is, as far as cancer management is concerned, for colorectal specifically, you have so many people come into picture. As I already told, the chemotherapy is there, so the medical college, radiotherapists are there. Again, we have a team of pathologists that plays a very crucial role to diagnose and to know whether we have performed a proper surgery or not, because they are the one who is tell us, like, okay, surgical specimen is adequate, margins, how far it is, roots are there, what is the type of the disease, so many things. Next comes to radiologist, like they will tell us the staging of the disease. Then you have, if you are preparing stoma, you have stoma therapist. Here, the stoma therapist will help the patient to manage the stomas if they are making. Then you have in the OPDs, you have, I told already, you have counselors will tell about whether the stoma is being prepared or not. Patient has to be mentally prepared. That is very important. So it's a holistic approach.
How do you see this branching on the, and what are the future scopes in colorectal cancer surgeries? And what do you expect from the advances?
Yeah. Over a period of time, since we got imbibed in cancer surgeries or onco-surgeries, the branches is evolving very massive there, because now we are seeing there is a malignancy almost every family. Even my family has malignancies. So maybe because of whatever reasons, lifestyle changes or pesticides, whatever we are eating, we don't know. But definitely, it's a very upcoming branch. It is going to be very far, and even government is supporting because they are also planning to open cancer centers in all the medical colleges separately. Plus, over a period of time, we are separating this branch in the form, like initially oncosurgery was a goal. Now we are separate head and neck oncosurgeries, gynae oncosurgeries. Now over a period of time, breast oncosurgeries and soft tissues are getting separated. So definitely over a period of time, things will change and more refinement will come in this branch. And aspirants will have a good scope as far as doctors are concerned. Definitely, it's not a good for the patients, but for doctors, yeah, my branch is going to be a very long now.
Thank, thank you, sir. It was so motivating for the future aspirants and future surgical aspirants to hear about colorectal cancer from a person who's experienced oncosurgeries from so long. And thank you so much for taking your time. And that's all we have.
Thank you, everybody.